Thank you, ma'am, for the opportunity. And invariably, when we see BLEBs, we have BLEBs which look absolutely flat. And that's the time when we think, what do we do? Do we do a second trab? Do we go in for an AGV? But I'll really telling you all, it's better to go in for reviving this BLEB. So what are the methods by which we can revive a BLEB which has probably failed? And don't think that that failure may occur in a few months' time. It may occur even years later. But don't think that this can't work. It can work. So this is what I'm going to try and show you. So if you have an avascular BLEB, an encysted BLEB, please go ahead and tackle it. So what do you mean by an ideal functioning BLEB? An ideal functioning BLEB is one which we would love to have a low-lying diffuse BLEB, very less vascularity. Cystic changes we would love to have. Of course, the intraocular pressure in low teens, well-formed BLEB with tight conjunctival closure. This indicates that the BLEB is extremely good. And what we commonly see, all of us, that we might have in the early period a failed BLEB with localized conjunctival hyperemia, excessive vascularization. Have a look at the blood vessels which are there. The corkscrewing is going to give you a lot of indication that this BLEB is probably going to fail. And followed by an increase in the intraocular pressure during the first month itself. Or later on, you might find that there's a small encapsulated BLEB, and these BLEBs you normally get to see in small children. So how do you manage it? First of all, you recognize your failure. You identify what is the cause of your failure. You naturally have to deal with the intraocular pressure at that time. You have to decrease the intraocular pressure so that your BLEB can survive and your intraocular pressure also decreases so that your optic nerve also does not get damaged. And you try to restore the BLEB function. So identify what is the cause of your failure. The most important thing, just like we always talk about gonioscopy, before to identify the cause of glaucoma, you must do a gonioscopy to check what is the cause of your failure. So you visualize the ostium. It's such a simple procedure. Have a look. Is the ostium being blocked? In early cases, you might find that your ostium may be blocked because of being incarcerated by iris, vitreous, ciliary processes, ciliary body, lens, blood, fibrin, name it, and it can block it. It can be again blocked late because of various things, like you might have a fibrovascular membrane in cases of NVG, fibrous growth, etc., etc. And we find, therefore, if you can identify the cause, then in that case, you can go ahead and treat it. Another very important thing, we always talk about digital compression for therapeutic purposes. That means you want to open up whatever is, but you can use it also to identify what is the cause, what is the problem which is causing this blockage, the obstruction to the flow of aqueous. So, and all of us know how to do the digital massage and try to do it by various techniques. Either you go beyond the BLEB, the margin of the scleral flap and press it over there, or you ask the patient to look slightly upwards and try to do a good massage. This massage must be done in your OPD. You must tell your patient how to do the massage, tell him clean his hands and ask him to look up, and invariably you will find your patient is pressing upon the bone out here. So you must tell him that he has to press upon the eye. Again, they are so scared that you have to show it to them and maybe do it on an attendant so they come to know how much of pressure should be applied. The other important thing is once you do it, then you see, okay, if the BLEB is formed and the pressure is lowered, you show it to the relative that, look, this is how your BLEB is formed. So your massage is going to make your aqueous flow and therefore your BLEB is going to work. This goes a long way in improving your BLEB function and patient function. So suppose, let's say you have done a digital compression, you might find that there has been a focal or diffuse elevation of BLEB, or you find that there's a resistance to this elevation. Now, if you find that your compression is failing to elevate and the internal ostium already done by gonioscopy that is free of any obstruction, then probably your obstruction is at the level of the external ostium. And if you find that there's a transient BLEB formation with a little reduction in intraocular pressure, probably your sutures are very tight. And tight sutures you can comfortably release. So what do? You try to remove the obstruction of the internal ostium. Let's say it's an early case. You've just done the glaucoma surgery and you find that there is a lot of vitreous is there or lens is there. You can treat it by means of argon laser or by ND-YAG laser. What I have not tried but I've found in books, I don't know if the August audience out here has anyone who has tried the recombinant tissue plasminogen activator. I believe that also works. Then you have to talk about removal of the blockage present at the external ostium. And that is where we need to work upon, because all of us know that even if you put mitomycin, invariably there is scarring. This scarring may take place just below the conjunctiva. It may also take place in between the scleral tissues. So you have to identify that and you must address that blockage. So we all know how to do suturelysis. One is what has already beautifully shown, how to remove the releasable sutures. These releasable sutures, only one thing I would like to say, that please do it in correct time, 15 to 20 days post-operative, otherwise after that it really does not work. Adjustable sutures, which has been again advocated by Pencor, I don't know how many people are doing it, but again that is a very easy method and can be done, and you can also address your BLEB in that manner. And of course suturelysis by means of laser, which are common techniques which can be used in order to remove the tight ones. The important thing is the conjunctival tissue, and keep on and on gently making side to side movements going ahead till I am able to release all the obstructing tissue. Along with that, if I find that the BLEB forms, then it is very comfortable. If it doesn't, I even go, like everybody else does, go beneath the edge of the scleral tissue and again go beneath that and try to, in fact, remove all the fibrosis which has occurred over there. If it is you are able to manage, even try to go through the ostium with the sclerostomy which is there, so that you know that your BLEB will form with you. Complications can definitely occur with needling. It can have hypotony, you can have suprachoroidal hemorrhage, malignant glaucoma, endophthalmitis, hyphema, wound leak. So don't take it lightly, it has to be done very comfortably. Along with that, we can also give bevacizumab injection. In fact, it is very good if you can identify corkscrewing of blood vessels present on the BLEB. Then in that case, even immediate, let's say maybe in 4 or 5 days post-operative, you can just inject a little bit of 1 milligram of bevacizumab, approximately very far away from the BLEB. You inject it, you find it does work. I've had a BLEB which really reworked the moment I did this, and I did it hardly, 10 days post-op itself. Now you might have BLEB encapsulation, which goes with the name of TENON'S cyst. Yes, I'll wrap up, ma'am. And the BLEB is loculated. It is dome-like, firm, thickened subconjunctival tissue. Maybe mobile. It has, of course, raised intraocular pressure. You can treat it with aqueous suppressants, give intensive steroid therapy, do digital compression, do needling, and lastly, you have to then, in case, do surgical do resurgery. What are the preventive steps? Try to minimize trauma by using a small perilimbal conjunctival incision, careful subtenon's dissection with a blunt instrument, do very careful cauterization, intensive use of corticosteroids, and cut tissue as anteriorly as possible. This will prevent tissue incarceration. Thank you very much for your attention.